Most people assume when doing IVF that it only makes sense to do PGT, it's only worth it if you have lots of embryos to test. But what if I told you that even if you only retrieve 3 eggs, it may still give you a major edge? A new study just came out looking at women with low ovarian reserve. These were people that retrieved 3 or fewer eggs. And guess what? The women that used PGT had a faster time to pregnancy, they needed fewer embryo transfers to get there, and they demonstrated an overall lower risk of miscarriage compared to those who did not use PGT. Now, I love this study because this finding completely challenges the notion that doing PGT in women with a low response may set them up for disappointment or failure. I see a lot of patients in my practice who are in their 40s, they have DOR, and they come to me for second opinions after having failed IVF elsewhere, and they'll say things like, I did IVF and I was told my egg count was so low that it made sense to just skip PGT altogether in case I have nothing or very few embryos to test. Or worse, sometimes I've heard patients being fed a false narrative that PGT could harm the few embryos that they may be able to create. But here are the facts. PGT is a technology that involves biopsying by removing a few of the cells from the outer part of the embryo that would one day become the placental cells if that embryo implants. And well-designed studies have actually shown that this procedure that's done to genetically test embryos, along with the freezing and thawing of those embryos, does not hinder the odds of an embryo being able to survive the thaw or to implant and result in a live birth. PGT is a screening tool to help us to identify the embryos that are more likely to stick and grow into a healthy pregnancy. And if you're trying to bank embryos for the future, knowing the quality of what you have frozen is really key, and it helps to guide accurate decision making on whether you could be benefiting from doing additional cycles to get more embryos for your overall family building goals. And if you're working with a limited number of embryos, just 1 or 2, to try and get pregnant now or in the near future, being able to pick which one to use first can make a huge difference. It can save you from months of uncertainty, from the potential time delay and detours and the heartbreak that miscarriages can bring, and often these can result from chromosomal errors that PGT could have identified and ruled out. Yes, it's true, PGT is not a perfect test. No test is perfect. One of the major flaws or downsides is that in order to be able to perform this test on embryos, you need them to develop to the blastocyst stage. So you need them to be able to separate out into 2 distinct cell layers, the future fetal cells and then the placental cells. And some embryos are going to be slow growing. Most often, these slow growing embryos have multiple chromosomal errors and age-related quality issues, but there can be some embryos that could have what it takes, but may be slow growing for other reasons. The vast majority of embryos that don't make it to PGT, we know from many experiments that have been done looking at this, they're usually so abnormal that they just couldn't get there. But a small sliver of embryos that are slow, but could have reproductive potential, might do better in a fresh transfer situation where you're putting into the embryo a week after the egg retrieval. So by foregoing fresh transfer and trying to wait for the embryo to look a certain way so you can test and freeze it, yes, theoretically, you may have missed out on an opportunity, and in some of those instances, perhaps transferring 1 or more embryos depending on the age of the eggs being used to make the embryos, and letting the uterus do the testing, so to speak, might be a reasonable option. Now, with this approach, if you're over 38, you're going to want to transfer the fastest growing 2 best blastocysts and then maybe freeze the rest if there's anything left to freeze. And over age 42, the guidelines say that it could be permissible to transfer up to 3 blastocyst stage embryos because you don't know their genetic status, they haven't undergone PGT. So you are gambling and taking on the potential risk of twins, even triplets. And these are high-risk pregnancies that we're trying to minimize or avoid, especially in older women in their 40s who are known to be at a baseline higher risk of certain pregnancy complications. I think the bigger, more realistic risk that everyone should keep top of mind with fresh transfers in this scenario is the risk of miscarriage. And sometimes these can occur in the latter half of the first trimester. And this can be significantly traumatic, both mentally and physically, and lead to the loss of valuable time up to 3 to 4 months. Now, don't get me wrong. I do perform fresh transfers. I actually heard recently from a new patient that I saw that there's a rumor, word on the streets is that our clinic that I work at doesn't do fresh transfers at all, but that's not true. There is still a role for fresh transfers when it comes to IVF. But am I ever going to advise straight out of the gate a patient in their 40s to forego PGT and plan for a fresh transfer as their plan A? No. I have used fresh transfers as part of my plan B. Sometimes it works, sometimes it doesn't, but it can be worth pivoting to if a patient consistently demonstrates difficulty with making embryos for testing. And trust me, I get it. I understand from the fertility doctor perspective as well as from the patient perspective how tempting it can feel to forego the idea of doing PGT and just stick to a plan for fresh transfer, especially if you only have 1 embryo or a handful of embryos. But here's the problem to remember. If you're in your 40s, at least 70% or more of embryos can be aneuploid or have the wrong number of chromosomes, and that can be taking on a significant risk for miscarriage or even a failed transfer. So yes, fresh transfer could be a good plan B if nothing can consistently make it to freezing or testing. But I really believe in the majority of patients, this should not be plan A, even if you have low ovarian reserve, because the odds of aneuploidy can be so high, especially for women at age 38 and older, that I think you're giving up significant, potentially valuable information by not doing it. At the end of the day, IVF is about stacking the odds in your favor as much as possible. And even if the stack of cards is small, every card you play matters.